we want to know which of these zones carry the riskier, have the riskier behaviors, and then interventions will be put up to help farmers, to help slaughters, to help retailers, and to help consumers to be able to prevent them from getting zoonotic diseases. And then we'll be using the socio-ecological model in interpreting all these factors that are influencing the zoonotic disease transmission for this research. Thank you.
Okay, thank you very much, Eunice. So that is the work Eunice wants to do, and that is the proposal she has. Any comments, any inputs, any questions? I would go first to our online audience.
Yes, if you can hear me, I guess I can go.
Yes, Prof, please go ahead.
Director, is Daniel here?
Oh, Daniel, I'm not seeing you. Your voice changed this morning. Sorry, please go ahead.
Thanks very much, Eunice. Maybe just in one word, what is really the ultimate goal of the work? I think I might have lost you in mid of the presentation. So what's the ultimate goal of it? Like if you could articulate it a bit more clearly. And maybe from the problem statement, perhaps that will come up.
So the goal of this work is to be able to know the behavioral risk that is found in the domestic meat value chain, that across the whole domestic meat value chain, in order to be, and looking at the sociocultural drivers, to be able to understand what makes people, because literature shows that people have a lot of knowledge about zoonotic diseases and they still go ahead with some of these risky behaviors. What we want to do is to understand why are these risky behaviors persistent. If you know that if you do this, if you handle animals, you have this direct contact with the blood and all that, you are most likely to get zoonotic diseases. You are very much aware. Why do you keep doing it? We are looking at the why aspect of it. So apart from the everyday, we want to also know the everyday, how we want to characterize the behavioral risk and know the level. These things that you even do you know how far it goes to affect your health and all of that? So basically, we are characterizing the behavioral risk and also explaining why these behavioral risks continue to persist in the value chain.
And the entire conceptual framework is the socio-ecological model.
Please come again.
You said the model you are using or the framework is the socio-ecological model.
Yes, please.
Are you sure that will cover all the possible reasons as to why?
Okay, so I chose the socio-ecological model because I wanted to combine it with the health belief model, but to some extent, I realized that from the individual aspects, because the ecological model includes the individual aspects to the interpersonal level, to the community level, and even to other structural factors. So at the individual level, that is where the health belief model can also come in, to be able to tell the the individual perceptions, the individual susceptibility, and all those things. That is why I actually chose to use the socio-ecological model for this. but then we are still reading. So if there be any other model to help bring out everything along the way, we'll add it up.
I will see to Prof. Walter from Kwame.
Yeah, thanks very much, Eunice. I'm still a bit lost about your understanding of domestic. I mean, it can have many meanings. Do you mean at the household level? Do you mean domestic in contrast to international? Or so what's the precise scope of domestic in your study?
So here we use domestic to mean domesticated animals. That's the opposite of wildlife.
Okay.
Yes, the opposite of wildlife. So we are using the domestic animals such as the livestock.
No, then it's clear. It's related to the animals. It's not related to the institutions or so. Okay, so I was surprised because, yeah, at the beginning we really discussed that we would work on bushmeat and spillover and all this. So that's really new for me. Okay, but thanks for the clear answer.
Thank you.
Okay, Prof. Emekwe, please go.
I just wanted to give, I know quite well that the domestic issue will come up, but we are looking at both formal and informal. If we use the word formal in Ghana context, we mean the cattle, goat, sheep, and all that. But we know quite well that there are slaughtering of donkeys, slaughtering of dogs in the north and all that. So that was why we used the word domestic, because she's going to look at both the formal and the informal value chain so that we'll be able to talk about spillover and some other diseases that we know that slaughtering of such animals is a risk. But if we use the word just meat value chain, we will not be able to differentiate between some of these. And that's why we classify it to both formal and informal. Then that will be able to help us to look at some cultural issues that surround meat value chain in Ghana. Over.
Okay, thank you very much.
Prof, wouldn't it be better to rather use the expression domestication or domesticated for the animal instead of domestic?
I think that would be taken. Thanks.
Thank you very much. Yeah, so I was wondering, looking at behavioral and sociocultural risk in a cross-sectional design, would we be able to get enough outputs from there? Because if the behavior, and you are comparing different regions, so Ashanti, Greater Accra, and their behaviors do change. And so are we not interested in behavioral change as well, or just one time points we think is enough?
Okay, that's true. But with the cross-sectional, we have the points one, and we could also have the interval one. So this is actually going to spread within a period of months. So yeah, it's going to spread within a period of months, especially during the data collection. And we are adding observations to it, which will all bring up some of these behavior changes.
Yeah, so if you say cross-sectional, then you are taking the sample at once. You are not following up. So even if it's within the month, it is sampling one time point. Yes. So maybe, I don't know, maybe the Prof. Emekwe and the others, we can think through and see how best we can get. So I'll hand over, we'll come on site and then we can go back online again. Prof. Newton, please.
Thank you very much. This is interesting, but my main concern is how you sample your respondents across the 3 ecological zones. Because we know that most of the people who work in that area are usually from the 3 northern regions, usually. So if you are sampling, you think you are getting a picture of what's happening across the country, and you are not careful, you'll be actually talking to the same group of people The only thing is that they are located differently. So how you sample your respondents for this work is extremely important. Otherwise, in the end, what you get is not actually representative of the 3 ecological zones in the country. It's just representative of maybe more of the same group of people located differently.
Yeah, mine is on how you selected the regions. 16 regions, 3 out of 16 regions. How did you select, or did you come about these 3 regions? And then what are some of the risk factors that you are thinking of that you think you will get from the people? Thank you.
So with the 3 regions, we know when it comes to the livestock production at the farm. So one of the things I have seen is that there are differences in terms of the value chain, the various nodes. There are intense, some are very intense in some regions compared to other regions. When we take the northern part like this, we can have more of the livestock farmers over there, which is by literature, it's noted that more are coming from there. Whereas we have in the south, the other nodes such as the slaughtering, and then the retailers. For the consumers, they are all over. So with the consultation with some veterinary officers and some officers from the Ministry of Health, they were able to help us with at least the peak regions where these activities do take place. And these 3 came up top, and then we also had a bit of the Volta region.
You have Upper-East, Upper-West, and some are more risky than others.
Yes.
So
please.
if you choose a region which is, not very risky, the question is, will you be able to get the data you want? You understand my question?
Okay.
So Upper-East, I don't know where you are going to work in Upper-East. It's in the Boku area, it's in a,
Yeah, so with that one, I followed up to the offices, but the one I was supposed to meet to help me with the district selections was not available. So we are still working on that.
Okay. Thank you very much. Please, do we have questions from the audience for Eunice? Yeah. Maybe I missed it. Are you sampling from the animal rearers?
Yes, we are.
Okay, because I didn't
The
see it.
commercial and then the household level as well.
Thank you very much. Yes, there's one question.
Thank you very much, Eunice, for that. If you'll be putting in any intervention by way of education, just so that you could improve the behavior of those who are involved in this meat value chain. Do you expect that the behavior will change? Are you putting in any intervention by way of education?
Okay.
Thank you.
So for now, we want to first of all know the behavioral risk. So after of course, we are interested in behavioral change. So there will be an intervention, but for now, we want to characterize the behavioral risk first to know which places need the interventions, and then we make a follow-up with the intervention.
Thank you very much, Eunice. There are no further questions. Thank you for coming. Oh, Daniel, you have your hand up. Oh, is that old hand?
No, it's a new one, but so maybe with your indulgence. So I was thinking in the same line that, okay, when you find and you're able to characterize or describe the behavioral patterns and so what, I think this may be not just a research ethical approval concern, but perhaps at the level of a PhD, it may be good to think whether it's possible to consider an intervention, perhaps, right? because it will always be, and so what question? It may make the study a bit bigger than it anticipated, but I still feel if you choose the right methods and focus your work, like Prof. Deborah's comment was, you may be able to get really the observational part of it, understanding what the risk really is, and then maybe spend some good amount of time on an intervention study. And to the point I also wanted to know is the various methods you are choosing. I'm not sure I saw any of these topics which will immerse you really into the community that you are studying to be able to study them in their natural setting. I'm trying to say that I did not see whether you are utilizing any of the sociological or anthropological ethnographic designs for your work. Maybe you mentioned, but I missed it. I will be happy to hear that. Yeah,
she mentioned.
Okay. All right.
She mentioned participant observation, focus group discussions. That would be, I think, sufficient.
Okay. Yeah. Okay, good.
Okay. So if we don't have
Ma, I don't know if I can say one or two things. We will look at virtually all the comments and we'll be able to come up with, we will incorporate them and make sure that it's a lot better than what we are presenting. I want to thank everyone. Thank you so much. Dr. Poku will come to see you so that we can discuss more.
Thank you.
Okay, thank you very much, Eunice, for the presentation. So now we are going to welcome our next presenter, which is Henrietta Tete, and she'll be presenting on the surveillance of viral pathogens associated with childhood diarrheal diseases in underserved regions of Ghana. So Henrietta, you have 10 minutes for your presentation and followed by 10 minutes discussion. So the floor is yours.
Good morning, everyone. I'm Henrietta Tete, and I'll be taking us through my proposal titled Clinical and Genomic Surveillance of Viral Pathogens Associated with Childhood Diarrheal Diseases in Selected Regions of Ghana. So my presentation will follow this outline. Now, diarrheal diseases remain a leading public health concern across all ages, but the prevalence is reportedly high in children under 5. And because of this, there's a lot of progress in reducing the incidence in these demographics. So we have the introduction of the rotavirus vaccination. And truthfully, this has led to some sort of decrease in the prevalence of cases globally. However, we still see a significant cause of mortality and morbidity associated with these diarrheal diseases in our low middle income countries. And according to Truga, there's about 400,000 deaths associated with this in children under 5. And out of this number, about 80% are in sub-Saharan Africa. So Combat tells us that in his report that the case is not different in Ghana, where we have about 9 to 12% of cases or childhood illnesses in Ghana being related to childhood diarrheal diseases. Now, with this burden or the figures showing as such significant burden, there is still limited, the etiology of most of these cases remain unknown in Ghana, especially with viral causes. So existing surveillance in our clinical settings focus on bacteria and parasites, ignoring the viral component. Even beyond our clinical settings, when you come into research, most of the research that has been done is focused in our urban and southern regions, neglecting several other rural areas. And within this research that has been done, there is also insufficient evidence that links the viral infections recorded to clinical outcomes such as severity and then death. So we have environmental and socio-economical factors being related to these. Meanwhile, they are not understood in several contexts. So enteric viruses are actually reported to be evolving rapidly. Meanwhile, we sort of tend to ignore those in our studies. And with this evolution around these viruses, we have new strains that are likely to emerge and may have different transmission and then even mortality rates. So the justification of this study lies in the fact that it will give us some sort of baseline understanding of what is happening on the viral interface. And then with this understanding, we can move forward to develop targeted interventions to reduce the cases in our country, Ghana. And with these targeted interventions, we are sort of going to strengthen our preparedness for any epidemic-prone viruses, so far as viral diarrhea diseases are concerned. With this understanding, the study sought to determine the prevalence, clinical impact, and genomic diversity of viral diarrhea diseases or pathogens among children. Now, to achieve this aim, the study will determine the prevalence of key enteric viruses, including nororota, adeno, and sapoviruses. Now, it will also move to assess the association between the viral infections and then the clinical outcomes, such as hospitalization. Now, there will also be a consideration or a characterization of the genetic diversity of the genotypes that are circulating, and then socio-environmental risk factors associated with these viruses will be assessed. Based on what is aimed to be achieved, the study adopted a prospective multi-site surveillance approach, which will be done at Tamale Teaching Hospital and then Rara Government Hospital. Now, Tamale Teaching Hospital is a tertiary hospital that serves the northern sector of Ghana, and then we have Rara being a district hospital. Even though it's a district hospital, it is still designated as the referral hospital for the Oti region. Now, ethical considerations will include an approval from the Ghana Health Service, and then permission will also be taken from the healthcare facilities that will be involved. Now, written informed consent will also be sought from the parents of the participants. The study will include both cases and controls. Now, following the evidence from Ofori in 2025, 394 cases will be collected and with the corresponding 394 age-matched children as the controls. And of course, caregiver approval will be sought before the study begins. However, children under 5 who are taking any antivirals within 72 hours of presentation will be exempted from the study. Based on the study design and then the aims, the first objective, which is to determine the prevalence of key enteric viruses, would be achieved by, so on sites at presentation, children will be screened before enrollment, and then they are aiming for children under 5. But these children should be presenting with symptoms of diarrhea, so lose 2, less than 3. Okay, so less than 3 stools within 24 hours, and then caregiver consent. When the samples are taken, they will be given unique identifications, and then, as I mentioned earlier, antiviral use within any patient will be exempted. Now, after enrollment, clinical and then biodata will be collected from the study participants. Then the stool samples will also be taken. With the stool samples that will be taken, they will be stored and then transported on ice. And at the laboratory site, nucleic acid isolation will be done, and then quantification will be done using qPCR. Now, the study outcome here is the prevalence, where we consider the percentage of positive cases from all the cases we will be getting. Secondly, the second objective is to assess the association between viral infections and then clinical outcomes. Now, at presentation, there will be a standardized clinical assessment to ensure that the symptoms are consistent among all participants. So from the first objective, we would be able to identify co-infections based on the positive cases that will be present. I mean, that is if they are present. And then from the clinical and then demographic data that will be collected from based on questionnaires, we will be able to determine whether there are clinical outcomes such as hospitalization and then severity. So severity will be assessed using the Vesicari score, where 20 is the maximum. And so they will be grouped, or cases will be grouped into mild, moderate, and severe. Now, all this information will be collated and a clean analytical data set will be formed, which will be analyzed in Stata. So here we would use descriptive analysis followed by bivariate and then multivariate to help us achieve our objective 2. Now, to understand the viruses beyond just the clinical characterization, objective 3 will look at the genomic or the genetic diversity of the viruses that are circulated. So the positive cases from objective 1 again would serve as the basis for objective 3. So library will be prepared, extraction will be done, then nucleic acid extraction will be done, then library will be prepared to serve as the viral material to feed into sequencing. Now, after sequencing, the raw data that will be generated will be assessed for quality control. If there's a need for any trimming on or any of such processes, that will be done to ensure that downstream processes are of high quality. Then genome assembly will be done and then mapping. Now, with genome typing and then phylogenetics, we'll be able to interpret the circulating strains. So literature tells us that socio-environmental factors such as wash conditions are very much implicated in viral diarrhea diseases. Meanwhile, these are less understood in theory, in practice. So the questionnaires that will be administered will help us understand the environmental conditions that are implicated as risk factors in these cases. The core variables that will be looked at here will be water source, sanitary facilities, and then hygiene, including washing of hands, including the general community factors, waste disposal. The results from this will also be analyzed in Stata. With this study design and methods, it is expected that the study will give us a general or a clear identification of the circulating enteric viruses. Beyond the numbers, we also expect to understand the characteristics or a characterization of the virus or the viral genomic diversity. And then beyond this, we would also have an evidence on clinical outcomes that are associated with infections. And then I understand the environmental risk factors associated with viral diarrhea diseases. This is my timeline, and thankfully, I am still on track. All right, my references, thank you.
Okay, and Rita, thank you for the wonderful presentation, and thank you for sticking to the time. So we move to the discussions, and we are going to start with our online participants. Please. Okay, yes, Professor Benjamin Emipke. Yes, Prof, we saw your hand. Yes, Prof. Professor Benjamin. Okay, then we move to Dr. Daniel Opoku, maybe in the meantime. So yes, Dr. Daniel.
Yeah, I will cede the lab-based work to Philip since his hand is up, and then I would rather consider, in this case, the wash dimension of the work. So you said to identify socio-environmental, and you put it into bracket wash, right? And factors and all. So the question is that, is there any wash community of interest as a target? Or what do you mean really when you say social environmental and then you say wash?
All right, thank you very much. So we don't have, as of now, we don't have any wash environment or a particular wash facility that we want to attend to. However, in the questionnaire bit, there is an assessment of wash conditions. So these people have, as to whether they have any hygiene facilities like toiletries, the way they dispose of their waste, if there is, or if they practice any hand washing activities before and after attending to the children. So these are children under 5. They are our cases, but the conditions in the environment in which they find themselves, the activities of their parents who are their caregivers have a direct impact on the outcome of diseases they present with. That is what we want to assess.
Yes, Dr. Daniel.
Yeah, yes. I mean, you said underserved communities in the title. Is that not it? Underserved regions, right? I think. So I'm just lost about how you determine the underserved regions in Ghana. What are you referring? There are 16 regions. Which ones are the underserved?
Okay, so that's an error there. The first ever proposal to be sent used underserved, and that is what was projected. But my proposal used selected. So there was the issue of that. What do we mean by underserved? The initial understanding that led to that word was from literature. We have a lot of studies going on around several places in Accra, for example. So we considered the places not represented in literature as underserved, but it was considered best to go for selected. So the current running title uses selected regions instead of underserved regions.
Okay.
Yes, thank you very much. Yeah, Dr. Philip, we have your hand. Thank you.
Yes, thank you very much, Nembot, and thanks for the very nice presentation, Hetty. Yeah, it's a curiosity because, usually as pathogen specialists, we tend to have like a tunnel vision on pathogens that are important to us. But there are other things like parasites and bacteria also around. So do you have any view to maybe also have a look at the differential diagnostics with respect to other organisms like parasites and bacteria, which could also serve as co-infections or in some instances may be the primary causes and not the viruses. So I think this is data that you probably also even get from the routine clinical diagnostics, but are you going to look at this aspect as well?
All right, thank you very much. So when we talk about co-infection, this bit that you just mentioned always comes up. Now, in our clinical settings, there's a lot of focus on bacteria and then parasites, like I mentioned. It doesn't mean that when we find viral case present, these other bacteria and parasites may be absent. They may be there, but the study of this, or the focus of this study is on viruses. So yes, we accept that this is the main limitation of the work, the fact that it is not going to consider bacteria and parasites. However, subsequent studies, if funding is available, could consider all 3 microbes across the board. Thank you.
I mean, as a follow-up, I don't mean that you have to test for them, but is it possible to get access to the data? Because this could, for instance, be an explanatory variable in your analysis if you don't check it or don't know what else is happening there.
All right.
I mean, just to consider, I know sometimes getting this data is also not easy, but in case it's available, this is something that you would consider as well. Yeah.
All right. So before drafting this methodology, for RARA, for instance, we have data on the available cases, available diarrheal cases in the hospital. So that data is available to us. However, the data does not tell us whether it is a particular parasite or bacteria. But I believe that if asked and the information is available, they are willing to let us have that, just as they gave us the numbers of cases that inform us to choose that facility as one of our study sites.
Okay, thank you very much, Dr. Philip. So if there's no other question from our online participants, then we move to our on-site participants. Yes, the first.
Thank you very much, Henrietta, for the interesting presentation. My concern is with the my concern is with the patient selection. So you mentioned that you are going to exclude participants who have been on treatment. And we know that you also mentioned that your study is not going to be focused on urban cities. We don't know yet where you are going to do your work, but the urban cities, they are served. So we are not going there. We are going to the underserved communities. And we have an issue traditionally here in Ghana, identifying the exact treatments that we have given to our children. And certainly a mother with a child with diarrhea would give something before they come to the hospital. But so how are you able to tell exactly what has been given to the child to determine whether it is an antibacterial, antiparasitic, or antiviral for you to exclude that person? How would you go about it?
All right, thank you very much for that question. So that draws our attention to something we need to look at. The initial plan is just to rely on the parent's information. If your parent says, I gave this, I gave that, and then what we know that to be is what we'll classify it as. But you bringing to light the fact that some parents don't even know the name of what they are giving to their children, but maybe a friend told them it helps, so they are using it. We might consider the possibility of excluding children who have been given any form of treatment, if that will help us, but that is still open to discussion with my supervisor. Quite will consider. Thank you.
Okay, thank you very much. Yes, Prof.
Just a very small comment. Whenever you are making a presentation and you have objectives, don't assume everybody understands the initials or the abbreviation, which you put there. Just try to make sure it's specific and clear so that we know what you're talking about.
Thank you.
Okay, yeah, so we take one question from.
Rita, thank you for your submission. First, I will find what diarrhea is, because you made a submission somewhere where I really want you to emphasize. You're saying the children, those that have defecated, sorry to use the word, 3 times, are going to those that to take your samples from. Whereby we all know that with diarrhea, it's supposed to be more than 3 times within 24 hours. Because some people will just empty their barrel 3 times and it's a normal thing. So can you kindly look at that section and then correct?
Thank you very much. I think I misspoke. I have greater than or equal to 3 loose stools for 24 hours. Thank you.
Okay.
Hello.
Yes, Prof. Benjamin.
Yes, thank you so much. I want to really sincerely appreciate this presentation. It was really nice. As a veterinarian, and this is GWAC, we'll be looking at diarrhea also in animals. And we know that there are some viruses that can easily be spilled over. And you are dealing with children that love to keep dogs, that love a lot of animals. I'm just looking at the socio-cultural issues. You really need to, especially with your questionnaire, how close are they with animals? What are the possible just like in the behavioral risk. What are those risks that is the children are exposed to because of their interaction with animals and their interaction with the environment? I think you should also take good note of that in your questionnaire, insert it well. The aspect I would have asked for, that was why I was dropping my hand, was the aspect of co-infection and co-interaction, especially in the GIT. When you talk about diarrhea, it's not just viruses. Viruses are more or less the starting point. Those that cause more of the real diarrhea are actually bacteria, because the immune system, the gut immune system have been highly compromised. So this aspect of interaction and possible spillover should be well taken care of in the course of your work. Over.
Prof, please, thank you. This is well noted.
Okay, thank you very much, Prof. And thank you, Henrietta, for the wonderful presentation. So straight away, we are moving to our next presenter, who is Joseph Buntin-Graden, and he will be presenting on assessing health systems' capacity to detect and respond to infectious disease threats in Ghana and Sierra Leone. So, Joseph, you have a maximum of 10 minutes presentation, followed by 10 minutes discussions. The floor is yours. Thank you.
Okay, good morning all. Good morning. Okay, and as supervisors and colleagues, all protocols observed. My name is Joseph Buntin-Graden, and I will be presenting on health systems preparedness. Thank you. Health systems preparedness and okay, apologies. Okay. So as I said, I will be taking you through health systems preparedness for pandemics, a comparative analysis of Ghana and Sierra Leone. And I chose this because of my background, being in emergency management for a while and going through a lot of upstream issues in responding to critical outbreaks in Sierra Leone and in other countries. And so this is my outline: introduction, study rationale and gaps, study questions, general specific objective methods, analysis, and the reference. So as it reads, the capacity of health systems to detect and respond to infectious disease threat is essential for global health security. More concerning is high-performing and resilient health systems were impacted by the COVID-19, and low and middle-income countries globally accounting for 58% of deaths by SARS. And most of us were aware of this, and we're acquainted with the impact of COVID-19 in our countries, and even the countries that we thought were prepared for highly pathogenic outbreaks like COVID were really caught off guard. And so the question remains, are our systems actually prepared, for pandemics? As we stand now, we're facing the situation of COVID-19, of Ebola, Buju, and Uganda as well as DRC are grappling with it. And globally, we're still not safe. A lot is going on the ground. And so you'll be asking, are our systems actually prepared in the case, let's say for Ghana, if Ghana is seeded with the outbreak, what happens? Do we have the systems in place? However, health systems and economies across member states of Africa have been recurrently disrupted by infectious disease epidemics with disproportionate impact on vulnerable populations. The international health regulations require state parties to develop and strengthen and maintain capacity to respond promptly and effectively to public health risks, according to the IHR framework. One of the expectations is that countries should build capacity to respond effectively to emergencies. Unfortunately, whether the case is so, that remains a question. In contexts like Sierra Leone, where I came from, there is a lot of gaps still exist, even though we have gone through the situation of responding to Ebola, and the literature speak that capacity is built. But recently we have the Mpox outbreak, which is even less virulent than the Ebola. And we grapple with that a lot. And so you ask yourself, are the systems actually built subsequent to that outbreak? So a study rationale and gap state that international public health concerns continue to grow over the potential threat posed by highly pathogenic viruses and their human pandemic potential. Meanwhile, the progress reports of national health systems capacity defined by the international monitoring and evaluation frameworks like the JE and the NAVS or the SPA for pandemic preparedness in Ghana and Sierra Leone remain unclear. And what do I mean by this? And just go back from what I mentioned. Like in Sierra Leone is the same situation in Ghana. When you read some of these documents, these are international frameworks that actually assess capacities. And you realize that some of the components are actually scoring high. But when the situation presents itself, it's totally different. As I mentioned, in my own case, we have risk communication, which is scaling high, which is 5 points, according to this external evaluation like the JE. But the typical situation like Mpox, we are not able to engage communities effectively. And so you want to ask, you are scoring 5 according to this JE when it attracted international partners and sat down. We sat down over a week to evaluate capacity and we shot at 5. But you had Mpox, you cannot effectively engage the community. So you're asking, are the parameters actually speaking in context to our system, or we are missing something? And so next, comparing Ghana's preparedness for pandemics with Sierra Leone and other DAD global health centers, valuable and measurable insight of regional strength and gaps could be identified for targeted action. The study questions now I brought forward is that is the health system in Ghana and Sierra Leone optimally prepared for pandemics like the Ebola? That's a typical situation we can ask ourselves. Are we really prepared for it? How effective is the implementation of the National Action Plan for Health Security, which has about 19 core capacities assessed? And in bridging the gaps identified in the J, this is an instrument after the assessment. It helps countries to actually identify those gaps and build capacity in preparedness for emergency. And how does collaborative surveillance between animal and human health sectors enhance detection and reporting of health threats? Of course, One Health is a concept that have been introduced that ensured that capacity is enhanced when we actually collaborate with other sectors. And so we're asking the question, that collaboration, especially between the animal health and human health, because it is less of environmental health, what value does it add to the health system in terms of detecting pathogens in early? And so with the general and my general and specific objective reads to assess health system capacity in preparedness for pandemics in West Africa, in context Ghana and Sierra Leone. And one, to assess the programmatic effectiveness of implementing the NAVs in Ghana and Sierra Leone. And objective 2 is to conduct a comparative analysis of One Health governance gaps in preparedness for acute public health events of international concern in Ghana and Sierra Leone. We want to understand what the gaps are. As I said, we have a lot of instruments that manages emergencies, but when the emergency presents itself, we throw away the instruments that we use, that should be used actually to contain the virus, and we bring new structures in place to respond. We want to look at those upstream gaps and to evaluate health information sharing with regional and global surveillance platform and its contribution to capacity building and evidence-based decision-making, which is critical, and to evaluate intersectoral collaborative surveillance practices between human and animal health and its effect on outbreak detection, risk assessment, reporting of health-related threats. So I'll be doing mixed methods of systematic health program review and systems research by virtue of what I will be studying. And the study setting, I will more focus on national public health institutes or agencies, as the case may be. My country, it is called agencies, and target this population of experts within the emergency domain. And the study approach or technique for objective 1, I will do a systematic review of IHR core capacities for health security using mixed method. And for my objective 2, I will use a cross-sectional policy evaluation, because using the mix of that, key informants or focus group discussion, as the case may be. And next, objective 3, so I will employ a mixed method approach to assess the dividend of data sharing, especially looking at collaboration between the two sectors.
Joseph, please, you should be rounding up, please.
Yes. And last, because I will also employ systematic review. So data collection will use this approach, structured assessment tools. These are frameworks which are available and can be utilized to actually enhance my work. Programmatic reviews, stakeholder surveys, and sampling, because from the qualitative point of view, it will be purposive because I know the target groups, and using snowballing in sampling. Quantitative multi-stage stratified sampling will be used across, because I will be looking at national and subnational level. Sample size, we use this app which helps you more to generate, the specific sample size that you want to use. Qualitative, as we all know, it is much more conducted until you ensure that there is no more new knowledge you are generating as you identify your participants. And my analysis will use framework analysis to help me in my analytic work. Thematic content analysis, I will employ that for my qualitative, as the case may be, and the quantitative analysis, descriptive statistics of performance indicators and multivariate, since I'll be doing with multiple variables as against my outcome. And so my study expectation outcomes read, and maybe I'll just state one: comprehensive inventory of national, regional, and global surveillance platform used for data exchange, documentation of reporting pathways, protocols, and governance structure. And one of my expected outcomes will be more effective sustainable integration of surveillance evidence into routine health system governance and emergency preparedness planning. This is my activity plan, which is subject to review as we progress, because the dynamics change when you get into the field proper. Thank you very much.
Thank you very much, Joseph, for the presentation. So now we are moving to our online audience for any contribution, any questions, or any follow-up. So, IT, online. Stop this. Yes, so, yes, Professor Wilm Quentin, you have the...
Yes, thank you very much for the presentation. I wonder whether you could maybe show again the objectives. In general, I'm very happy to see how this is developing, because I remember when we initially had the idea for this study, and that is quite some time back now already, and to see now how this is coming together and being much more specified and concrete in terms of what you are intending to do. And I think it can really make a real contribution potentially to getting a better understanding of the capacity to respond to future pandemics. So I see it's really key to kind of the objectives of GWAC. Maybe one question I have is, so in terms of how many, I'm not sure I captured how many countries you intend to analyze, and whether this would focus only on Ghana, West Africa, or potentially also include other countries, because I remember initially we had the idea to potentially also compare with the countries of other global health centers, and whether you see the potential to do something like that.
Yes, of course. Thank you very much. And in context, we actually focusing on Ghana and Sierra Leone, but definitely in the process of time, looking at what unfolds, it might determine which country we might bring on board. But keep in mind that we're also having an external eye, because we're making comparison with other structures, especially for the health system, not just restricting it to West Africa. We want to see what obtains in other jurisdictions, so we can see what can be learned or what are best practices that we can bring on board. So in the process of time, with the engagement, of course, of my able supervisors, I'll be advised as to what other context we can bring to add value, and apart from Ghana and Sierra Leone. But for now, our restriction is Ghana and Sierra Leone, taking in mind also resource constraint. But all other things with the systematic review, we can look at the inclusion and exclusion principles and see what other countries we can bring in that context. Because we are talking about pandemics, so it's West Africa. Let's see what we can glean from other countries.
Yes, thank you very much. Yes, Professor John Amoisi, thank you.
Chair, and thank you, Joseph. Follow up from Wilm's comment. It would be nice, of course, if we can include other countries, including, or particularly those from the other centers. But I believe for the purposes of the PhD, we would maybe restrict this to Ghana and Sierra Leone to allow for some degree of depth, given that these are both Anglophone countries in West Africa, considering also that Sierra Leone has had significant exposure to outbreaks vis-a-vis the Ebola, and then the COVID also was faced by Ghana, but the Ebola was much more focused on in Sierra Leone. So it'd be interesting to do this comparative analysis between these two countries and see how structures perhaps built during the Ebola may have supported for the COVID, and how embedded these are in Sierra Leone as compared to Ghana, which has never had a significant outbreak with heavy mortality of casualties as Sierra Leone had. So I think we're still at the drawing board. But already, as you mentioned, Bill, it's getting more focused, and certainly will be very exciting work, especially given Joseph's exposure at the level of the Africa CDC, the wider West African level. But again, we can always consider a broader project beyond the PhD, because I think it could be very interesting and important.
Okay, thank you very much, Professor John Amoisi. If there's no other question from our online participants, then we move to our on-site participants. Yes, the floor is to Dr. Michael.
Yeah, thank you very much for the presentation. It's quite an interesting topic, but you know that this topic is also sensitive. Looking at, the experiences that we've had in Africa, where anytime you raise the subject of preparedness, it is looked at it from two perspectives, technical perspective and political perspective. The politicians will always want you to know that the country is well prepared. So if you want to ask for data, it is difficult to get a data that clearly represent the state of the country. Unless pandemic strike, then they are forced to tell what is happening. How are you going to overcome this? Sierra Leone, Ghana, in the PhD work, I believe you will be publishing this data. You'll be showcasing weaknesses in systems for the world to know. How will you overcome issues of sensitive data, approvals from various agencies to give you that support to be able to show what truly represent these two countries?
Yeah, thank you, Dr. Michael, for that question. And definitely, this is a situation that I'm also facing currently. I was also doing the work in Ethiopia and analyzing some data and having restrictions. And this also obtained even in my own country. And that is why in the study, based on my experience, you may have challenges actually in engaging probably authorities to elicit the cogent data that you need. But because of your choice of your sampling, because you want to ask questions that, that bears on the country. And so they alone could not provide the answers. And so you will have to engage other people, to actually get the information that you want. Because you see, research, you're pursuing that data that you want. And so you have to choose the right people. Nonetheless, even when you elicit that data, there are data that are sensitive. I hope this conference is covered. There's a situation I face now. I elicited data from a country, and the government, the government is shutting down certain statements. And so for me, it affects the integrity of that research because it's not bringing out the true value. As you give you a typical situation, J reads 5 for risk communication in my country, but Mpox, you cannot handle it. You get me? And I understand the situation because we are covering up, and Africa has this problem. Well, as your question says, that calls for skill. That is why research is not done by a single person. You need the collaboration of other experts, and how best you can penetrate the community, or yes, the community of experts or government policy makers to get the data and make them understand that that data is important. Because if we don't bring out the gaps, how do we attract support? And so again, it all depends on you. Because I always tell people, for example, even to get them to interview, I don't call authorities to sit with them 30 minutes. I just ask for your 10 minutes. And I know you ask for 10 minutes. When they start, they will want to take you 30 minutes. Just ask for 10. They will give you the 10 minutes. Don't say, I want to interview you 45. No, they don't have time. Just, I need 5 or 10 minutes with you. When they begin to talk, they will take you 1 hour. And so you just employ skills, ask others how best it can be done. I believe with the support of my supervisors and other researchers on the field, they will get better with it. Thank you very much for raising that.
Yeah, thank you very much, Joseph. Actually, would have loved to get more questions from the on-site audience, but due to time constraints, I think we'll have to move on. So thank you once again, Joseph. So our next presenter comes in the name of Venus Nana Boache Frimpong. He'll be presenting online, and his work is on from environmental surveillance to antibiotic stewardship in Ghana, a mixed method approach. Yes, Venus, are you there?
Yes, please, I'm there.
Okay, thank you very much. So we shall be sharing your slides, and
okay, so
yeah.
then let me take it down.
Yeah, so share.
Venus, can you please have your camera on?
Okay.
Venus, can you share from your end, or we should share from our end?
I could share from my
It would be better she shares from her end.
Okay, okay.
Yes, please I want to know if my slides can be seen.
Not. Yeah, we can see you. Yes. But you are not yet on slideshow.
Okay, yeah.
So thank you, Venus. So you have a maximum of 10 minutes presentation, followed by 10 minutes presentation. The floor is yours.
Okay, thank you very much. I'm trying to, okay. Yes, so good morning, everyone. My name is Venus Frimpon, and I'm here to present on the multi-level determinants and drivers of antimicrobial stewardship and antimicrobial resistance trends in Ghana and mixed methods One Health study. So this is going to be the outline of my presentation. So delving into the introduction, antimicrobial resistance, which is a phenomenon simply explained as microbes' ability to evade antimicrobial activities, undoubtedly poses a great threat to public health and health system sustainability. According to a study by Murray et al. On the global burden of antimicrobial resistance, an estimate of 1.1 million deaths have been attributed to AMR in the year 2001. And across sub-Saharan Africa in that same year, an estimate of 209,000 deaths have been attributed to AMR also. And in Ghana, 4,910 are attributed to AMR itself, and 23,100 deaths that have been associated with AMR. Now, the current situation is compounded by limited environmental surveillance, inappropriate antimicrobial use, challenges in stewardship, and gaps in governance. I found this image quite interesting for the first reason that it says reducing antimicrobial resistance, and that's to just reiterate the fact that we cannot prevent this, but we could only reduce it, except of course we are able to take away the ability of microbes to become resistant. And if you look at all the measures that the author of this picture tried to put together, one thing I could tell is that we need robust guidelines and policies in place to make sure every single measure we see here is fully followed or bettered out to ensure that we can reduce AMR. So even though the national AMR action plans and stewardship guidelines exist, there is still inappropriate use of antimicrobials across the One Health sectors. And more so, there is a structural, behavioral, and governance factors. The structural, behavioral, and governance factors influencing the implementation and adherence to AMS, that's antimicrobial stewardship practices, as well as AMR trends are poorly characterized, particularly issues that concern stocking, pricing, and distribution of these antimicrobials in medical stores, veterinary hospitals, and livestock farming. And so there's the urgent need to generate integrated One Health evidence on the environmental, structural, behavioral, and governance determinants of AMR in Ghana across the human, animal, and environmental interfaces. And this because AMR is a quintessential One Health challenge, and it is driven by the interconnectedness of all these sectors. So that's a way to go. So because of that, this research project aims to utilize a One Health approach to conduct a comprehensive analysis of the environmental determinants, structural implementation factors, behavioral determinants, and government systems influencing current AMR trends in shaping antimicrobial stewardship practices across the three sectors of One Health. So specifically, we we want to conduct a scoping review to map evidence supporting the interconnections between environmental AMR surveillance, antimicrobial use, and resistance emergence in Ghana. And the second would be to assess the levels of selected antimicrobial residue in wastewater from high susceptibility sources, and to evaluate their ecological risk using the risk quotient framework, while establishing the correlation between these residues and the abundance of ARGs in the receiving environment. We would also like to assess antimicrobial availability, the pricing structures, distribution practices across medical stores, veterinary hospitals, livestock systems in Ghana, and to explore their implications for antimicrobial use patterns and stewardship practices. The next will be to explore the behavioral determinants of adherence or to the divergence of AMS guidelines, and to evaluate the effectiveness of AMR structures, regulatory frameworks, and the standard stewardship policies among human and animal health sectors in Ghana. And we would like to triangulate all of these findings to identify a potential pathway or potential pathways contributing to AMR in Ghana, and to develop evidence-based strategies for strengthening antimicrobial stewardship and to reduce AMR risks in general. So this study, we hope to employ a cross-sectoral convergent mixed methods approach, and then which would involve reviews, quantitative methods, specifically descriptive and correlational ones, qualitative participatory methods, and by way of stratifying them according to objectives. The first objective, as we said, that we would want to conduct a review, a scoping review would, so we would select high impact journals from some publishing sites, electronic databases, and then we would perform the scoping analysis by getting charted data, or like the mapping, do the mapping to be able to stratify and then come up, to be able to get the charts of whatever interconnections we would find. So using the Prisma for scoping review. And then we would, with objective 2, which has to do with trying to assess the levels of residue, antimicrobial residue in high risk or high susceptibility wastewater. We would use the high performance liquid chromatography to estimate the levels, and then also use the risk quotient framework to assess its selection to AMR, and then to identify antimicrobial resistant genes that may be present in the wastewater. And we, with objective 3, we would use quantitative survey and a checklist assessment to assess the antimicrobial availability, pricing, and then distribution of these antimicrobials in medical stores, etc., as mentioned earlier. And then with objective 4, we hope to conduct in-depth interviews and focus group discussions to assess the behavioral determinants of stewardship practices, and also employ the use of the COMBI model, or the theoretical domain frameworks to assess the do a behavioral analysis. And with regards to policy analysis or stewardship guideline review, would also conduct a key informant interview just to understand all that there is that goes into the behavioral determinants of stewardship practices and the barriers to the adherence divergence and the implementation of these guidelines. And lastly, having gotten data from all of these individual objectives, we would want to triangulate these evidence to have a comprehensive data that could be used to inform strategic interventions towards reducing AMR.
Venus,
Now,
please, you have 2 minutes to stop.
Anticipated, yes. So thank you. To our anticipated outcomes, we hope that by the end of this study, we would have a mapped interconnections between antimicrobial use, environmental contamination of antimicrobial residues, and then the AMR trends across the One Health sectors. That's from environmental AMR surveillance evidence that from existing environmental AMR surveillance evidence. Then we hope to have a baseline data on antimicrobial residue contamination, ecological risk, and the occurrence of antimicrobial resistant genes in high-risk water systems. And the evidence, at the end of it, we hope to also gather evidence on antimicrobial availability, the affordability, and the distribution pathways across the 3 sectors, whilst we also identify structural factors that influence antimicrobial use and stewardship practices. We also hope to get an understanding of the behavioral determinants of AMS compliance or non-adherence, and also identify barriers and facilitators to the implementation of the guidelines across the sector. They are supposed to go by across the sectors. And to have a triangulated One Health data for tailored strategies to strengthen antimicrobial stewardship intervention, surveillance integration, and AMR governance to ultimately mitigate AMR risks. Thank you. These are my references. Thank you.
Thank you very much, Venus, for the wonderful presentation. So we are moving to our online participants for feedbacks, inputs, or any question. Yes, Dr. Daniel. Okay, yeah, thank you. Any question or any feedback from our online participants? Yes, Professor William Quentin.
Yes, thank you very much for the presentation. I'm very happy to see this topic, also how it is developing, and I'm glad to be your supervisor, and to see this. So I was just, can you maybe show again the different objectives or the So in fact, I wonder, so you mentioned AI in the I think I saw AI in the title, but I wonder how important AI is in the topic really, in the objectives. Could you?
Sorry, there's no AI in here.
There's no AI in the title. Oh, then it was wrong maybe in the program really. Can you go back to the title?
Okay.
Okay, yeah, that makes sense. Okay, good. Then maybe another question on the objectives would be, but I think it's something that we will discuss more in the next few weeks. That it seems you are putting yourself up, that you are very ambitious, and that is good for PhD students to be ambitious. But I think this sounds like it will be a lot of work, and maybe we need to see over the next few months how we could maybe reduce a little bit the anticipated work that you want to do, while still keeping it ambitious enough to be an important project. But maybe looking at these 5 objectives, is there something that you feel is more important for you than others? So if you were to select 3 of the 5 objectives, which ones would you select as the more important parts of your PhD?
Okay, thank you very much, Professor Vilm, for that question. If I were to select, I would go for objectives 2, 3, and 4, mostly because objective 5 typically is triangulation of all the data, which I could still do regardless, yeah, as an additional for the end of the entire study. And I'm choosing those because I feel like those are fundamental to to do something novel in the space of the in AMR studies. I did a little bit literature search and I realized that there isn't even enough environmental surveillance data to start with. So if I was to do objective 2, it would not only be adding to my work, but also add to what others have already done. Because from my search, I realized that there's only 6 published work in Ghana on wastewater environmental, let me just say environmental AMR study put together. So I would want to do those, and then basically also because the objectives 3 and 4, as I said, would really add that new light to understanding AMR and how we're able to find some antimicrobial residues in the environment, because I feel these have direct bearing on what we are seeing in the environment and the kinds of resistant strains that are coming up. Thank you.
Yes, thank you very much, Venus. Yeah, Professor Amoisi, we have.
Thank you very much. Thank you very much, Chair. Yeah, just in line with Vilm's comments, as we had already discussed, and that we need to, cut down on the objectives a bit. So I'm fully aligned with this. Definitely very exciting work. I'm particularly interested in the comments of Dr. Michael Owusu, given that this is also a space where he has significant expertise. So I think we'd also benefit from his comments. And if not now, certainly as this work progresses. Thank you.
Prof, we can't get you properly.
Yeah, yes.
Oh, I'm sorry. Can you hear me better now?
Yes, Prof.
I was saying that I agree with Vilm's comments on the need for the objectives to be reduced. I think I'd already discussed this with Venus, and this will be done. Of course, we are now in just the scoping and framing, shaping phase of the work. And I was saying that the work is certainly exciting and very relevant. And I would love to hear comments from Dr. Owusu, given that he has expertise in this field as well. I know he is also running projects that are along this line. So if even not now, certainly as the work progresses, would love to have his input and benefit from his expertise. Thank you.
Okay. Thank you very much, Professor John Amoisi. So we move to our in-person audience. Is to Professor Newton.
Thank you very much. Mine is a presentation issue. The School of Graduate Studies says that we should use Harvard. And when we are training you, that's what we do. But when you are presenting and you have 1, 2, 3 inside, how do you know what you are talking about? You have to carry your audience along. Your references, when you show something and you show the source, at least they know, they can tell what you are talking about. Yes, your presentation was very good, but your Vancouver, you couldn't carry us along. Thank you very much.
Thank you very much, Prof. Yeah, if there's, okay, we have one question. Yeah.
Thank you. Thank you for the. And of course, for the presentation, I don't know whether I missed it, but I wanted to find out where exactly is your study site, and then your study participants, because you mentioned focus group discussions. Wanted to know if you are interviewing some key stakeholders when it comes to the AMR issues.
Okay. Thank you for that question. I will be interviewing key stakeholders, specifically pharmacists, livestock farmers, and all that. I didn't put them in the slides because we are yet to get into the details of all of it. Already, as two of my supervisors have said, we are still working on taking down some of the objectives. So yes, for now, this is what I have, and I will be interviewing key stakeholders as that. I mean, like the ones I mentioned. And I think you asked someone a study site. Yes, especially with regards to. So generally, it's across board. I meant there are some in the objectives, for instance, medical stores, and all that. We would select veterinary hospitals. We would select these, and then we are hoping to have them all in a particular area, maybe a municipality, so that we can link everything we are doing, especially when we are hoping to do this environmental analysis and wastewater analysis, so that we can map it to these hospitals and veterinary hospitals, medical stores, and all that in the same vicinity. Thank you.
Thank you very much, Venus. So currently we are having a snack break. So there's a snack break going on. However, we will be continuing with the presentation. So those interested, those who want to go and have their snack break, they can have it. However, the presentations will be going on. So
yes, please. So you can step out for snack. After snack is the poster session. So you go for poster session and then you come back here. But G-WAC presentation is ongoing. So if you are not hungry, you can stay on. Or if you pick the snack and you feel you want to listen more, you can do so.
So thank you very much, Venus. So we are moving on to our next presenter of the day, who is in the name of Ben Nkrumah, and he will be presenting on AI-enabled antimicrobial resistance surveillance systems, trends, impacts, challenges, and opportunities for Africa. Bernard, are you there?
Yes, I'm here.
Yes, thank you very much. So please, you have a maximum of 10 minutes presentation, followed by 10 minutes discussions. So the floor is yours. Thank you.
Thank you very much. I'll be making a presentation on AI-enabled AMR surveillance systems, trends, impact, challenges, and opportunities for Africa. This will be my presentation outline. By way of background, antimicrobial resistance
antimicrobial. Bernard, are you in a position to turn on your camera? It would be good to.
Yes.
Show that.
Bernard, please enable your video.
1 second. Okay.
Okay, fine.
All right, thank you. So antimicrobial resistance, AMR, has definitely become one of the critical global health issues as far as this is concerned, within this 21st century. And AMR really threatens the effectiveness of modern antibiotics, and by so doing causing millions of deaths globally, in Africa, in Ghana, in most parts of Africa, and then other parts of the world. Africa and then most part of Asia are bearing the greatest brands of AMR, and there have been quite a number of challenges that have been attributed to AMR. Key of these have been lack of effective surveillance systems, inadequate laboratory capacity or infrastructure, fragmented health data systems, and poor antimicrobial stewardship programs within these settings. But recently, we've seen a lot of advances in artificial intelligence, in machine learning, and these really present a lot of opportunities to improve on disease surveillance systems and then health data analytics. So our problem statement is that what's happening? Effective AMR surveillance systems are limited due to either a fragmented data systems or manual data reporting systems. And once a data system is fragmented, then it means that we are not having a complete picture of AMR or antimicrobial use and stewardship situation within a specific context. Whether it is a fragmented data system or we are using manual data systems, the challenges are you are not getting the right data, or if you get the right data, the entries are done wrongly, and so the quality of the data is bad. And once the quality of the data is bad, then definitely you will not be able to analyze those data and get the needed feedback or the needed outputs for which interventions can be based on. Recent advances in AI technologies have presented opportunities to improve disease surveillance. And even though we've seen a lot of advances in AI, AI adoption in AMR surveillance systems remain very low in Africa. And this also have been attributed to a couple of reasons, inclusive of which poor infrastructure, limited capacity, whether it is financial, human resource, and then governance, policy, and so on and so forth. We think that for justification, AI technologies are capable of processing complex data sets. And by doing that, it's able to detect and predict AMR patterns. It's able to detect and predict AMR trends. And so AI technologies is able and is able to perform and provide solutions that helps in improving AMR surveillance much better and faster than the current systems that are being used. And AI algorithms trained on large data sets can outperform traditional monitoring methods in predicting resistance trends and informing targeted antimicrobial stewardship programs. And so for this study, we're looking at the potential AI technologies in enhancing AMR systems in Ghana and in Africa. The aim of this study is to investigate the role of AI in strengthening AMR surveillance in Africa, with a focus on identifying the trends, assessing the impact, and addressing implementation challenges. Specifically, we'll conduct a systemic review of the current AI-enabled AMR surveillance systems in Africa. We want to analyze data on antimicrobial stockings. We want to look at prescription patterns. We want to look at microbial isolates and the AST data from the laboratories. And by looking at these data and analyzing them, we should be able to triangulate these data to be able to come up with some trends and some predictions. And then also identify technical, infrastructural, policy, and governance barriers affecting the adoption of AI-enabled AMR surveillance systems in the African health systems. And finally, we hope to, based on data we've collected and analysis we've done, we should be able to propose a framework for implementing AI-based AMR surveillance systems suitable for the African context. By way of our research questions, we want to look at what are the current trends, in the use of AI for AMR in Africa. How can AI technologies improve the integration and analysis of antimicrobial use and resistance data in African health systems? What are the key infrastructure, technical, governance, and policy challenges that are affecting the adoption of AI-enabled AMR surveillance in Africa? And then what are the strategies that can facilitate the effective implementation of AI-driven surveillance systems in resource-limited settings? So this will be a mixed methods study. We'll be looking at both qualitative and quantitative methods. In terms of our settings, in Ghana, we'll be looking at the AMR Sentinel sites. There are some AMR Sentinel sites dotted across the country on both the human, animal, and environmental sites. So we'll be taking a closer look and select some of these Sentinel sites to work with. For the other parts of Africa, we will be looking at AMR data sets, such as the GLASS data sets, and then be able to use that in our data analysis. For ethical considerations, we will be applying for ethics from the KNUST School of Medical Sciences. We'll also be applying for ethics from the Ghana Health Services as well. We'll make sure that we seek permissions from all the AMR Sentinel sites. For our systemic literature review, we'll conduct a comprehensive systemic review to identify the existing studies on AMR applications, on AI applications in AMR surveillance with specific focus on Africa. We'll be looking at databases such as PubMed and others, and we're using keywords such as artificial intelligence, AMR surveillance, machine learning in healthcare, AMR monitoring systems, digital health surveillance in Africa. And so once we use these keywords, we would go through, we'll go through a systematic process using the PRISMA guidelines so that we are sure that our systemic review is going to follow the preset guidelines in performing this study.
You have 2 minutes left, please.
We will examine the data sets we will examine the data set, and so we'll be collecting data from AMR stockings from pharmacies, from hospital stores. We'll be looking at prescription patterns from the clinicians, consulting rooms. We'll be looking at laboratory data, and we'll put all this data and then have AI algorithms run these, and then be able to have forecasting and then come up with some trends and some analysis that we can look at. For our stakeholder interviews, we look at a semi-structured interview, and we'll be doing this with health workers, largely doctors, nurses, disease surveillance officers, anybody within the health sector that is involved one way or the other with AMR. And by so doing, we should be able to gather and have some insights into some of the challenges that are likely or the limiting factors of AMR based surveillance in Ghana. By doing this, we expect that we will have AI enhanced data integration across antimicrobial supply chains, clinical prescriptions, laboratory-based surveillance testing. We also hope that we would have a framework for the implementation of AI-enabled AMR surveillance systems. And then the study is expected to contribute to the current state of AI-enabled AMR surveillance with special emphasis on latest advances in application in Africa. This, for now, is a timeline we are looking at. Is still work in progress. And these are a snapshot of my references. Thank you very much.
Thank you very much, Bernard, and thank you for sticking to the time. So we are moving to the discussion session. We start with our online participants. Yes, Professor Velm Quinton, we have you. Thank you.
In fact, I think Daniel was first. So I would see to him.
Yeah, Vil, thanks very much. And let me get on with it. And Bernard, thanks for the presentation. This is a show of understanding of the field and the scope of the work that you want to do. However, I would assume that there are still some tightening to be done as far as, for example, the problem statement is concerned, the objective of your work, and the related parts. So one of it, let me take it from well, you said the expectation. In fact, one of the objectives is to propose a framework, really. So if you're proposing a framework, my understanding will be that framework will be informed by the other objectives of the research, the findings from those objectives that will help form it. If that is the main work, then that should reflect in the main objective, other than to investigate. Do you get it? So you may have to add the framework agenda also as part of the work, if that is so. Then the next part of it is you also said that we will develop AI enhanced AM. It's not what your work will do in the expected outcome. One, I'm afraid your work is not an intervention study, so you will not necessarily be able to develop AI enhanced. Well, but if it is the interest, because I remember we've had this conversation before, if it is the interest that we will really want to develop an AI-enabled surveillance system, then let's approach it also aside and clearly of the work that can do. I think the other point is the objective, and then the two, more or less the systematic review or the variant of it. It's not too clear in details what is the review objective. Do you get it? So you will notice in our earlier conversation, I mentioned that I do not see the difference between the review objective and the second objective, right? So I had mentioned, and now it's clear just from the data point of view that you will want to analyze like the stocking data and the other, and more secondary data analysis. But with that, we will need to be clear on what really the review question is. Yeah. Over.
Thank you very much, Dr. Poku. So those are well noted. I'll reach out so that we refine and tighten the loose ends of the work. Thank you.
Okay, thank you very much, Dr. Daniel. Okay.
I think now Prof. Quentin can go, right, Phil?
Yes, Prof. Quentin.
Yes, thank you also from my side for the presentation. It's interesting and great to see that you're planning to also look at the use of AI for AMR surveillance. I was wondering whether you have been in touch already with Venus, as you are both working on AMR. I think it would be really helpful for you to discuss with each other how to delineate and delimit the different topics, and potentially to see how you can benefit from each other also in joint data collection on some of these aspects. So I think it would be really good to see you working as a group on this work on AMR surveillance.
Yes, that is absolutely correct. I'm in touch with Venus. Well, she's my buddy now, so we will definitely be working together on this. Thank you.
Okay, thank you very much, Prof. Quentin, and thank you if there's any question from our own, yes, the floor is to Professor Deborah.
Yes, thank you very much, Bernard. Yes, and yeah, I also realized that a lot of tightening will have to be done here. I'm just concerned about the sampling approaches. No, not the approaches, the targets. So you mentioned that you are going to look at prescription patterns. I'm just wondering what you mean by that and how you are going to do it. Is it over a period of time? Is it for a particular area? Or is it among a particular group of people? And so, I mean, it's something we have to look at, I mean, together with other points that really needs to be tightened. I look forward to your presentation again in September. And there I will look forward to seeing it more tightened for us to get a clear roadmap. Yeah.
Thank you very much for that. That is well noted. Thank you.
Thank you very much, Prof. So if there's no other question, we are moving straight to our next presenter. Thank you very much, Bernard. Thank you for your presentation. So our next presenter comes in the person of Benedicta Bando, and she will be presenting on biofilm formation and immunological profiling as drivers of community-level antimicrobial resistance in lymphatic filariasis endemic northern Ghana, a One Health approach. So Benedicta, you have a maximum of 10 minutes presentation, followed by 10 minutes discussion. So Benedicta, the floor is yours. Thank you.
Good morning. So I'm presenting on drivers of antimicrobial resistance in lymphatic filariasis endemic areas in the northern part of Ghana. And the aim, so AMR occurs when microorganisms manage to develop or acquire mechanisms that causes them to evade the action of antimicrobial agent that would originally kill or inhibit their growth. And we realized that in LF communities, because LF patients usually have secondary bacterial infections, which is managed with antibiotics, they are prone to the risk of AMR. And there's increasing global recognition that to tackle the menace of AMR, we need to use a One Health approach. And so the local practices of the patients is such that they have open wounds, and then because of the infection, they walk barefoot. Most of the time, they are unable to wear shoes because their leg is swollen. And then they also rear animals. And then the animals, when they poo or they poo, they use the feces of the animal as manure for their farmlands. And their farmlands are in their homes. They farm in front of their homes. So there's a constant connection between their feet, the animal feces, and then the soil. So the aim of this study is actually to look at the One Health approach. However, in Ghana, regardless of the body, a lot of the research has been done on AMR. There's still some form of gap. In 2024, Donko et al. Did a systematic review of the genomic studies that have been done in Ghana. And they realized that only 3 studies were done concerning the environment where AMR is concerned genomically. Majority of them were human-based, and then they were siloed in the clinical settings. And so there's a fragmented research going on in Ghana, and we need to address that. That's one of the gaps. Also, we realized that there's a geographic gap. In LF endemic communities, in Ahanta, where some form of work has been done on AMR, but in the northern part, AMR work is ongoing. That's what Takeoff is doing now. So there's no published data on AMR in LF endemic communities where the northern sector is concerned. The only work that has been published, which was published in 2025, they looked at the water quality of the environment. And so this work is quite relevant because it addresses a key gap. And no work has actually looked at combining ARGs, that's the antimicrobial resistant genes, biofilm genes, and then horizontal gene transfer markers together. There's a lack of evidence in Ghana generally where this is concerned. The biofilm genes are responsible for infection persistence, and then the HGT markers, actually, when you see them, it shows that there's a potential for dissemination of resistant genes between the reservoirs we are looking at. And so the justification for this work is that when we are able to sorry. Okay, so as part of the problem statement, I did sorry. So as part of the problem statement, we realized that their local practices also could spread and lead to the dissemination of AMR. I did a pilot study between January to April 2026, and then I realized that 88% of the 60 people I interviewed said that they do open defecation. And actually just one person had a toilet in her home. I also realized that their hygienic practices are poor. About 82 people responded yes to not washing their hands after using the toilet. And then also the animal contact was 97%. And so this proved that truly there's some form of, there could be some resistant genes that could be circulating if we investigate that. And the justification is that when we conduct this, it will be the first comprehensive study in Ghana on genomic AMR surveillance amongst the LF population. And that could serve as a baseline data for subsequent studies. And also the LF population is a vulnerable population, and so and they are understudied. So researching into them will help us address a key One Health gap, as well as it will help us to understand the genomic spread of AMR. We'll have a clear understanding as to how molecularly AMR is spreading, so that we can find ways to mitigate or disrupt the spread of AMR in biofilms, which lead to persistent infections. It would also help us to be able to contribute to policy and then interventions, integrated interventions, where all the three reservoirs are concerned. The main research question is in the LF endemic, surroundings, do we have antimicrobial resistant genes, biofilm genes, and horizontal gene transfer markers circulating, and are they spatially distributed? Or what are the hotspot areas of distribution that we should target for interventions? So that is the key research question. And the hypothesis my aim is to be able to investigate into the persistence and then the dissemination of AMR by conducting a genomic surveillance of antimicrobial resistant genes, biofilm-associated genes, and horizontal gene transfer markers, and also map the distribution of these genes to identify hotspot areas of resistance in the Upper East region, which is the Kasena Nankana. The specific objectives is first to determine the prevalence and the distribution of the genes. And then the second objective is to be able to culture and identify the clinically relevant isolates and determine their phenotypic resistance. The third objective is to be able to characterize a selected portion of these resistant genes and reservoirs using metagenomics and then the WGS. And then the last is to identify the spatial distribution of these genes to know the resistant hotspot areas. The methodology, the study design is a cross-sectional design. And the study site is a Kasena Nankana district in the Upper East region of Ghana. And the population is humans, animals, and the environment. The specimens will be taken from humans. A human specimen have been taken already. We collected skin swabs and wound swabs from the humans, and then we'll be taking animal feces and we'll be taking soil. But the essence is to look for clinically resistant pathogens that were found in the humans. We are trying to look for them in the animals and the soil. And the laboratory procedure will follow this pattern. So we'll first do culture and identification to be able to isolate the organism. And then we'll do the sensitivity to be able to tell the phenotypic resistance. The reason being that when you do the molecular test, you can tell that the gene is present. But as to whether the gene is being expressed, you may not be able to know. And then after that, we'll do DNA extraction, and then we'll do PCR, and we'll do sequencing. The essence of the PCR is to screen for all the genes that we are looking for. Then when we see overlap of the genes, the one where there's shared resistance, we do sequencing to be able to understand better what is happening. And then after that, we'll use the data from the sequencing and the PCR results to be able to do the spatial mapping. And so there's a metagenomics, and then that's the whole genome sequencing, the approach that we'll be using. Data will be handled using Excel, Stata R, and Cytoscape for network analysis and visualization of the spatial analysis. This expected result, we want to know the prevalence of the genes, shared resistance across the reservoirs, we want to be able to tell the phenotypic resistant patterns, be able to develop interventions. We should be able to come up with a policy relevant insight for Ghana's AMR action plan, and also be able to do a comparative analysis of the shared resistant genes, the clinically significant pathogens that we identified. A comprehensive profile of them, will receive that through the WGS. Impact of the studies will be the first comprehensive study on genomic AMR surveillance in the LF population. And then also it will support improved wound management, antibiotic use, and be able to help in improving quality of the LF patient. Lastly, it will support Ministry of Health actually in its approach to handling the One Health surveillance at the district level. Dissemination of findings will be done through journaling and then conference presentations. This is my work plan and timelines. That's my estimated budget. And then ethical considerations will be sought. These are my references. Thank you.
Thank you very much, Benedicta, for the wonderful presentation. So now we are moving to the discussion and the inputs. We are starting with our online audience. Do you have any hand? Okay, yes, Dr. Manuel, you have the floor.
Thank you very much for the nice presentation. I have a question to the sampling. So you said that you want to, that you already have the samples from the lymphedema patient. Do you also consider to take samples from non-lymphedema patient as a comparison?
Yes, please.
Okay, thank you.
Control. So the human samples we took from non-LF patients, that will be done.
Perfect. Thank you.
Thank you, Dr. Manuel. Okay, if there's no follow-up from our online participants, we move to our
I'm not sure if this is only my side, but I cannot see anything anymore or hear anything.
Same here.
Okay. Okay. Maybe we lost the Ghana one, guys.
Seems like it.
Yeah, G-WAC KNUST is on mute, but this is Linda, or?
Or Patricia? I don't know.
Oh, yeah. Oh, okay. They will be back soon. Okay.
Okay, thank you very much. We sincerely apologize. We had some technical challenges here, but we are back. So we are having a follow-up question from Professor Linda Debra. Thank you.
Yeah, thank you very much, Benedicta, for the presentation. So you mentioned that you are going to take samples from the human, animals, and then the soil and look for the pathogens. So certainly we are going to have a lot of pathogens that are you interested in any pathogen at all that is causing resistance, or you are narrowing down to say bacteria or viruses or?
Thank you very much. So the human work is ongoing. So based on the findings of the human work, we'll look at the most top 3 dominant resistant pathogens, and then look for them in the animals and then the environment. But it will come with discussions with my supervisors so that we look at which pathogens based on the findings of the human study. However, if the human study, I have 3 pathogens in mind: Staph aureus, E. coli, and Pseudomonas, because of the wounds. But based on the findings of the human study, we'll be able to tell better which clinical pathogens to go after in the soil and the animals.
Thank you very much. We have one question from our online.
Okay, thank you very much. I am Al-Hassan Abdel Nasser Tarbaou, PhD students from Department of Pharmacology. My first comment is to appreciate Benny for this work that you put out to do. I think the One Health approach is currently one of the quite clear approaches that we could adopt to study AMR, because it's let us appreciate that concentrating on human contamination wouldn't be able to solve, because there are dynamics related to that because of our interactions with animals and then the eco-environment. But my question is, first question is, what informed your choice of the study site, that is Kassina Nankana district? The other is, what considerations will you have in the choice of samples, soil samples to be taken for this particular study? If you could give us some clarifications. Thank you.
Thank you very much. That's a very good question. So the choice of study sites, and we have 2 major endemic areas in Ghana, the southern.
The first round presentation, which is the cohort G-WAC cohort 3 or phase 2 cohort 1. So the next presenter We are starting with the GWAC cohort 2. The first presenter is John Boateng, who will be presenting on characterizing the skin microbiome and immunological response in filarial lymphedema patients to determine the role of dysbiosis in acute adenopharyngitis attacks. So John, you have 10 minutes presentation, followed by 10 minutes discussions. Thank you.
Thank you very much. My name is John Boateng, and I'm presenting on characterizing the skin microbiome and immunological responses in filarial lymphedema patients to determine the role of dysbiosis in acute adenolymphadenitis or attacks. So this will be the outline of my presentation. So to lay a background to my presentation, so lymphatic filariasis is a parasitic infection that is caused by mosquitoes. And once people get bitten and they get the infection in their system, with time, as the years pass by, they develop certain pathologies, either lymphedema, that is a swelling of the leg, or enlargement of the scrotum, that is hydrocele. Some ways surgeries are being conducted for hydrocele patients, but for lymphedema, the mode of care is management. And one peculiar thing about lymphedema is that these patients go through what we call adenolymphadenitis attack. It's a big word, but simply what it means is that episodic inflammatory episodes that is result in pain in the leg. So we need to be able to manage this condition so that we alleviate them from the pain. And secondly, there are stages to this infection, or let me say the pathology, grading from stage 1 to stage 7. Stage 7 being the most severe form of the lymphedema. But we need to understand how a patient from stage 1 progresses to the next stage that is leading to the most severe form, so that we can either halt the process and also be able to help them have a better quality of life. The second thing that we are also looking at is that the attacks that are caused, it also affects the immunological profile, and we really want to understand to what extent does it affect the immune responses. Not much work has been done in this area as actually investigating or characterizing what happens to the immune system exactly during the period that they are going through the pain. So the objectives of our study, one is to determine, identify the bacteria or fungi that's associated with the cause of these attacks, and two, to characterize the skin microbiome, in other words, the normal flora of the skin. Then the third one is also analyze the antibiotic patterns of the most relevant of microorganisms that may be contributing to the cause of the attack or the progression of the condition. The objective 4, I just spoke about it, that is to understand the immune profile. And the fifth objective is to also try and investigate whether there are changes in terms of white blood cell counts during the period that they are going through the pain, to see if there are changes that are significant to the cause of the attack, then we could possibly harness this as biomarkers for treatment, monitoring, or follow-up. Then the C is also to assess whether there are certain comorbidities like diabetes, hypertension among these cohorts, and to see to what extent do they also affect in terms of wound healing and also progression of their condition. And lastly, to compare. So we did our group did a study about 7 years ago. The study is called Early Disease Clinical Trial, where we try to use doxycycline to manage the condition. So we want to compare the current quality of life of these patients as to then, and see whether there's been improvement or deterioration. The methodology is so simple. So first of all, we consent the patient. We take clinical data from them. We take blood samples, swab samples from the skin and also from wounds if they are present, and also blood samples. Then we culture these swabs, isolate the microorganisms from them. Then also the blood samples are separated, which will be used for the immunological analysis, and also blood cultures are also conducted during the acute phase of the inflammatory episode to also find out whether there are bloodstream infections. AMR work will be done on the most relevant pathogens to find out whether there is antibiotic resistance, because these patients normally make use of a lot of antibiotics during the period that they are going through pain to manage the condition. The study is being conducted in the Katsina Nankana, that is the municipality, and also the West District in the Upper East region of Ghana. The field work has been completed. We recruited 162 early patients, 50 healthy controls to serve, healthy people to serve as controls. We are also looking at among the cohort, that is a 162, with those with wounds, whether they have diabetes, and to compare the infections in these diabetic ulcers to actual diabetes patients to see whether there are differences in terms of the infection. So these are some pictures from the field work that we have conducted so far. And these are also some field work that we did in terms of laboratory work that were performed in the field laboratory. So these are some, let me say, preliminary findings based on the recruitment. So we have recruited 132 patients who are, in Group A. Group A is grading the lymphedema stage from stage 1 to stage 3, and also 30 people from grade 4 to grade 6. We didn't recruit people from grade 7 because it's hard to come by them. Those people are always bedridden and they are not accessible within, or you cannot call them to also have an interaction with them outside. Even though I'm saying that grade B is stage 4 to stage 6, there is no stage 4 within our cohort because we didn't find any of such. Among the 162, we also realized that 32 of them or 31 of them at the baseline also had wounds, and those who had wounds, we had that is 11 of them who were diabetic or who are diabetic. So this is demographic data regarding those who have currently experienced ADR attacks. There are 17 of them, 3 of them being males and 7 of them being females. The average age is 52 years, and among them, only 3 of them had wounds during the period of the attack, and 2 of them were diabetic. So we've cultured these skin swabs, wound swabs, and collected all the microbes that grew on our culture media using conventional methods like blood agar, chocolate agar, maconke, and all that, subarachnoid dextrose agar. So we collected these organisms to assess them later on within the study. But this is just a summary of the stages I talked about, I explained earlier on. So you can see that these are the numbers that we have recruited in each of the stages that we have in our cohort currently. This graph is just also reiterating that the lymphedema can affect either one leg or both legs. So one leg is unilateral and bilateral means that those they have both legs being affected. Then the number of people who have wounds at every stage, and also with diabetes as well. In terms of comorbidities, we realized that people with lymphedema and hypertension, we had 29.6% of them. Then comorbidity, 30.2%. And having hypertension or obesity and also lymphedema, they are 6.2. So this is a chart showing the attacks that we have recorded and the cause of the attack, or in other ways, the trigger of these attacks. We realize that out of the 17 people, about 15 of them had injuries to the affected leg, leading to the pain that they experienced. And the stages that actually experience the pains are stage 2 up to stage 6. So regarding the isolates I talked about that we've collected, these are the numbers that we currently have in our biobank that we will be assessing to actually identify what specific microorganism these numbers make up, and also to follow up and do antimicrobial sensitivity tests to see whether they are any resistance, whether they are responsive to the current drugs that are being used for the management of ADL treatment or not. So what we saw was baseline. This is the AD attack, but this particular one has to do with, so baseline, we have 32 people with wounds, and also 7 people during the attack also having wounds. So this figure also looks at the skin microbiome of the patients who experienced the attack. So this one, we are just focused on the 17 people, their microbiome before the attack and their microbiome right after the attack. And these are the numbers we can see from there. So we realize that in group A at baseline for bacteria, we have 144, which what they call increase to 173. Likewise, we have that is 89 for the group B, also rising to 115. So in conclusion, what I would say is that our current findings indicate that the triggers of AD attack has to do with injuries to the lymphadematous leg, and diabetes, hypertension, and other comorbidities may also significantly impact their quality of life and needs to be managed so that they can have, a better life altogether. And lastly, our findings also emphasize the need to strengthen what we call hygiene-based intervention. That is the current intervention in place to help these patients. And we've realized that from our previous study that when patients observe strict hygiene protocols for, regarding the leg, washing it morning, sometimes afternoon, and also evening, either 3 or twice a day, it helps either to halt the condition. In other words, not becoming severe. Not, let's say if a patient is at stage 3, it may help not to progress to stage 4 or stage 5 or 6. So that is an intervention in place, and we enforcing it would also help. In those with wounds, we also need to get potent or sensitive antibiotics that they can use to treat these wounds, and also to be able to ensure that there is antibiotic stewardship among these people, because most of the time when they have this attack, they resort to over-the-counter antibiotics in order to manage the condition. So the way forward is that we are going to continue with our laboratory investigations, trying to identify these microorganisms using Marditov, and also assess the AMR patterns using both phenotypic and genotypic methods, and assess also the immunological assays to see whether these ADL or the episodic inflammatory attacks remodel the immune system. Thank you very much. So these are our collaborators, sponsors, and my supervisors. Thank you very much.
Thank you very much, John, for the wonderful presentation. So now we are taking feedbacks, questions, or contributions. We are starting with our online audience. So do we have any? Okay, for now, there is no hand. Yes, Professor Linda Debra.
Yeah, I think, for us as GWAC, what would be very interesting is to see your timelines. You know that to hear, to see or know when you are ending.
Thank you very much. So regarding the timelines, what we intend doing is let's say by close of this month, we'll be starting with the microbial identification. That's the isolates that we've collected in terms of identification. We are hoping that looking at the number that I presented, within it will take like 2 to 3 months to be able to assess all these isolates to be able to tell exactly what their identity is. And because we will have to know the identity of the organism before we can proceed to assess our AMR, because we can't assess AMR on all the over 3,000 organisms that we've collected. So we will need to narrow down on the most relevant ones. And so we will need to complete this work in the next 3 months. Before the following month, we will be able to do our AMR assessment. For the immunological work, we are hoping to start in September to be able to do the immunological work, and that was going to take us a month, maximum 2. So I'm hoping that by close of the year, we should be able to have our data ready. Yes. So the plan is that the thesis will be ready up to the methodology level, so that once the results are tripping in, analysis are ongoing, and the full thesis can be completed within a month. Once the results are ready, the entire result. I'm hoping
because we are all witness.
by December, once I have my results, by November, the immunological work, by December, I should be done.
December 2026.
Yes.
Thank you very much.
Okay, thank you very much. Yes, Prof. Newton.
Yeah, thank you. I'm just curious. I know this is not a case control study. I know this is not a case control study.
It's a cohort study.
It's a cohort study, I know that. In choosing your controls per case, you rather have more cases to control, 162 LF cases to 50 controls. What was the reason for choosing that?
Okay. So the initial plan was to have a 1:3, that is controls to cases, 1:3 ratio. So the plan was to have 50 controls as to 150 early cases. Even though we ended up with 162 cases over the 150, the reason to that was because we recruited the baseline participants to a level, but the essence of the work is to look at the cause of the ADR attacks. But the participants that were recruited were not experiencing the attacks. Then our objective will not be met. So then what we sought to do is to actually recruit those who are having the attacks, who are now part of the cohort at the moment, so that we can actually achieve the objective. So that ended up with the 162. Yeah.
Thank you very much. Yes.
Thank you very much, Mr. As part of your presentation, I saw one of your considerations where you have, as part of your subjects, you try to elucidate those who are diabetic, pre-diabetic, and then diabetic. What protocol do you have in diagnosing people to be pre-diabetic and non-diabetic? Could you tell us the protocol you?
Yes. So there is a standard way of classifying that. So the gold standard for diabetes diagnosis is HbA1c, that's glycated hemoglobin. we don't normally use the fasting blood sugar, random blood sugar as diagnostic because people can have that is their sugar levels being unstable, but then when you do the FBS or RBS, it may be normal at a particular time because it fluctuates throughout the day. So the gold standard is the HB1C, which looks at the stability of the sugar level around the RBCs over the past 2 to 3 months. So we do this test, and anyone who have the results, okay, beyond 5.7, okay, that is so let me put it this way. So from 3 to 6.4 is the range. Okay, so once you go beyond 6.4, you are diabetic. But if you are from 5.7 up and below 6.4, that is pre-diabetes. Okay. Pardon? Non-diabetic. Non-diabetic. So even when we say you are pre-diabetic, doesn't mean you are diabetic. It simply means that if certain things are not checked within in terms of your lifestyle, you could proceed to being diabetic. So all of them can be classified as non-diabetics. Anything below 6.4.
That or to give those two considerations, because having a clear cut between product as a nomenclature to non-diabetic, I mean, it looks to kind of create some kind of unclarity, unclear position on that. So, like your explanation, don't you think considering only two, what is the name, descriptions will be fair enough?
Yes, you are right. But in terms of management, it's also important to let people know their status so that certain intervention can be put in place. They don't end up being diabetic. Because, for example, if I come to the hospital and I'm diagnosed and you tell me I am not diabetic, it's as if I can continue my lifestyle. But if you tell me I'm pre-diabetic, it means that if I don't check my lifestyle, I could get diabetes. Then it's I mean, it speaks more to me to look at what I should do next so that I don't end up there. I don't know if you get what I'm saying. So what your suggestion is welcome. We can classify it into two. It is it's okay, and you can also look at it into three. It's a WHO standard. So
yeah.
Well, maybe I don't know, but if I was clear, I mentioned that per the protocol, 3 to 6.4, okay, is the normal range for any normal human being who is not diabetic. Beyond that, you are diabetic. So there's a clear line there. Okay. Then the 3 to 6.4, we are saying that you are non-diabetic, right? But in terms of management and also helping you not to get into diabetes, we have also classified the non-diabetes people into two, okay, which is 5.7 or below. So below 5.7, you are not diabetic at all, or you don't have the risk of developing diabetes. But beyond 5.7, you have the risk. Therefore, you have to check your lifestyle. Okay, thank you.
Yeah, very much. I think your point is very apt. And of course, if you are doing research, you have to be clear on finishing. So it is very arranged and so, I mean, thank you.
Thank you.
Okay, thank you very much, John, for the wonderful presentation. If there's no other question from both our online and on-site participants, then we move straight to our next presenter of the day, who comes in the name of Gideon Kwaten Echampong. He will be an online presenter, and he will be presenting on determinants of 2020 to 2022 COVID-19 mortality in Ghana. evidence from routine surveillance data. Gideon, are you here with us? Gideon.
Yes, I have just shared my presentation. I don't know whether it is visible to all.
Yes, it is visible, but not yet on slideshow. Okay, thank you very much. So Gideon, you have a maximum of 10 minutes presentation, followed by 10 minutes discussion. The floor is yours. Thank you.
Okay, thank you very much for the opportunity. My name is Gideon Kwatine Champong, and I'm working on the determinants of 2020-2022 COVID-19 mortality in Ghana using evidence from routine surveillance data. My supervisors, Prof. John Amoisi, Prof. Nakwa, and Prof. Quintin. This is the outline of my presentation. Okay, so by way of introduction, the COVID-19 pandemic has had devastating effects in terms of the number of deaths on the health of millions across the world. And then it is important to look at the disparities in mortality, especially within the context of low and the middle income countries. Disparities in COVID-19 mortalities may reflect patient level factors, health facility level factors, or certain contextual variables that cannot be necessarily measured. So it is important to understand that there are drivers of mortality and that we need to look at it to inform pandemic preparedness and outbreak response. It is important to look at mortality rates and its distribution, irrespective of the incidence or despite issues with the COVID-19 incidents, because it is important for understanding the risk groups, guiding the targeted interventions following infection of these of COVID-19, and then, as I said before, preparing for future outbreaks. With respect to Ghana, the number of death counts rose, let me say, exponentially from 2020 to 2021, and the country recorded more than 3 times the number of deaths that it recorded in 2020 when the pandemic began. And as a result, Ghana was one of the highest, the countries with the highest death counts for COVID in West Africa. And more importantly, the incidence and then the mortality and as well as the mortality rates varied from district to district, from region to region, and additionally from facility to facility. In terms of the general objective of the study, with the background that we talked about on risk, understanding risk, let me see, groups for COVID-19, the study is looking at determining the determinants or predictors of COVID-19 mortality in Ghana, then specifically to examine the distribution of the mortality across hospital levels, that's primary, secondary, tertiary hospital levels, investigate the population level determinants of COVID-19 mortality, examine facility level determinants of COVID-19 mortality, and then to look at perspective of frontline health workers on the determinants of COVID-19 mortality at the facility level. In terms of methods, the study design used was a multi-phase mixed method design, specifically a sequential cross-sectional quantitative to qualitative. So the study was organized in 3 phases. That's phase 1, phase 2, in 4 phases, I beg your pardon. Phase 1 to phase 4. Then the geographical and temporal scope for phase 1 to phase 3, there was all cases that were recorded in Ghana. And so we used 260 districts as at that time for the number of cases for the surveillance line list. And then the facilities were about 1,107. The data in terms of temporal scope is spanned March 2020 to February 2022. And for the data sources, we used the data from the Ghana Health Service Disease Surveillance Department and then for facility level secondary data, we used quite a couple, again, from the Ghana Health Service Institutional Care or Clinical Care Division, Christian Health Association of Ghana, and then the Private Health Facility Association of Ghana. So that does it for the secondary data. Then for the primary data, we looked at interviews from health workers. So for phase 1, which looked at distribution of the mortality across hospital level, it was largely qualitative, quantitative variables like age, sex, facility level, the GPS coordinates, district and residence of cases were used alongside their outcomes. Then for analysis, we did descriptive studies, chi-square test for association between all. Sorry. Hello. Can you hear me? Did you say I should pause? Okay. Yes, I can hear you now. Okay, cool. All right, sure.
Yes, we apologize for the inconveniences. We had another technical challenge here. Yes, so Gideon, please, the floor is yours. Kindly continue.
Okay, can you hear me now?
Yes, please.
Okay, thank you. So for phase 4, we did a qualitative study where we selected the top 5 facilities with the highest mortality and the death. We looked at these 5 facilities with the least death rates. And then we do these facilities. We selected 16 health workers.
And please, we can't hear you
Sorry,
properly.
we can't hear you anymore.
Is it a bit better now? Can you hear me?
Yeah,
Yes.
All right. So we selected the top 5 and then the bottom 5 facilities. I indicated 8 here because in the results, those we just had persons from 8 facilities after the interview. And so then we did a thematic analysis and then did the coding where we grouped into sub-teams and teams. And then we decided to ask them about their perspectives on the COVID-19 mortality determinants within their facilities. And then they suggested mitigation measures as well. So in terms of results, we had a little over 150,000 COVID-19 cases with 1,442 deaths. Within hospitals, we had 46.7 cases recorded in hospitals, and the majority of deaths also were recorded within hospitals. That's 1,210. In terms of distribution of mortalities and cases, most of the cases and mortalities were seen within the southern sector of Ghana. And then in terms of case fatality rates, we had primary hospitals recording the least case fatality rates, about 10.1, and followed by secondary 14, and then tertiary at 16%. In terms of population level case fatality rate, that is looking at all the cases and all the mortalities that happen in Ghana, we had 0.91% case fatality rate, a median age of cases for about 45 years, and then for deaths, 77 years. In terms of comorbidities, chronic hypertension and diabetes were the largest chunk of these comorbidities. So they combined had about 80% of persons who died who had comorbidities. In terms of regional and case distribution of mortalities and of cases, for cases, Greater Accra region had the highest chunk of the cases, and then for mortalities, again, that side by side the population, Bono was the most affected alongside Ashanti region, which recorded about 7 mortalities or 7 death counts per 100,000 persons. In terms of the population level determinants of mortalities, there was an increasing relationship or a positive relationship between age and COVID-19 mortality. So increasing age was associated with COVID-19 mortality, where we had the odds ratios to be 5 for the 60 to 69, 8 for the 70 to 79, and then 23 for the 18 and above. For sex, the males had a higher risk of death. And for comorbidity, the higher your comorbidity, then the higher your chance of death. So for the comorbidity, that's a Charlson's comorbidity index. For the person who had the CCI of 1, their chance of death was 2. And then if your comorbidity X was 2 or greater, you had a chance of death of 3. And so for the regional average household size, the higher the household size, then the higher the risk, which is a adjusted odds ratio of 5. Population density wasn't significant. And then for epidemic waves, we had quite some unusual results after adjusting for epidemic waves. In the literature, the wave 2 was seen as the most virulent, but then in our study, we had quite an unusual finding where wave 4 was, let me say, the most or the highest risk of death when it came to epidemic waves, particularly owing to maybe issues of data, let me say, completion or data quality issues within the data set we use. Then for phase 3, for the hospitalized cases, we analyzed just 8,453. And then we looked at the number of deaths to be 1,100. The number of, in terms of age, we have 49 years median age and then 63 years, which was lower than the population level determinants. And then we also looked at certain facility variables and then the epidemic waves as we have it on the slide. In terms of the correlation coefficient, we realized that there was a weak positive correlation between death counts and then the number of beds, number of doctors, number of nurses, mainly owing to the fact that most of these beds, nurses and doctors were in the higher level facilities. So usually it's expected that higher number of beds, higher number of staffing, lower chances of death. But this time, because there's a certain referral bias, we saw more let's say a positive correlation between the death counts and then the health capacity variables like beds, nurses, and doctors. In terms of the regression, for facility variables, again for age, sex, and then the CCI was the same. I mean, the patient level variable, age, sex, CCI was the same. For facility level variables, persons within the secondary and tertiary hospitals were at a higher risk of death compared to the primary level, again owing to referral bias or the greater concentration of more severe cases within the higher level facilities. The same was also observed for staffing. Again, because you are likely to see more staff in the higher level facilities, it appears that you will have a higher chance of death there, not because those facilities were bad, but mainly because there were more, let me say, severe cases in those facilities. And then we looked at the qualitative study where we looked at experiences of health workers and then their, let me say, opinions on the determinants of mortality. And we picked out some of their experiences in terms of work overload during the pandemic, emotional strain of staff, where some staff talked about the higher workload during the pandemic, and then others too were scared. In terms of management of severe cases, most of them had a protocol for management of these severe cases, but then they had challenges. For example, a nurse in a secondary facility talked about the fact that they had to ration oxygen. So she said, if someone is at, say, 94%, then, but we do not have enough oxygen, that's oxygen here, we have to take him off and then to save another patient who is at a lower oxygen saturation pressure. And then for the individual level determinants, again, we had issues regarding age, and then comorbidity, and even the male sex. But other determinants were the rapid deterioration before diagnosis, and then health-seeking behavior. For example, diagnosis was late, referral was late, and then they died as reported by a doctor. And then some too, they had poor perception. Some, let me see, respondents or health workers reported that they had bad perceptions regarding COVID-19. For example, a lady mentioned that she was confined on lice because she didn't have COVID. She didn't believe she had COVID, and that was quite a sad incident for what was happening in the country during that time. In terms of facility level determinants, persons talked about human resource, equipment, oxygen, as previously mentioned, and then referral issues. For example, it said treatment centers did not want to receive cases because they knew the case would die. So if, let's say, a facility is referring a case to another facility, the facility that the case is being referred to will ask for certain variables of the case. If they realize that the person is about to die or will definitely die, then they say they don't have a bed, and then they don't have equipment. And that was quite an issue during that time. In terms of the mitigation measures that were suggested, again, improvement of service delivery. The doctor talked about deployment of rapid response teams, and then some talked about quarterly training to address weaknesses, and then some talked about refining data so that it can give more meaning to what is happening. And then equipment. We need oxygen plants. We didn't have enough during the COVID, as a midwife reported. So in terms of the summary of the findings, so COVID-19 mortality was influenced by patient level and facility level, as well as contextual factors. There was male sex, there was higher age, and then there was comorbidity burden. Regional average household size was also a problem. And then the cases and mortalities were displaced towards the southern regions of Ghana. In terms of the facility level determinants, as previously mentioned, secondary and tertiary hospitals had higher, had patients who were at higher risk of death, not because of performance, but likely because of the referral bias, and that more severe cases were in these hospitals. The same reason for the interpretation of odds ratio for staffing. In terms of contextual issues, there were issues like referral bottlenecks, limited ICU oxygen plants, increased risk of COVID-19 mortality. And then workforce pressure was also another issue. So basically, these have been, let me see, the findings from the study. And in terms of the progress, PhD progress, of course, ethical clearance has been done, data collection, analysis, the draft 0 report of the thesis has been done. And I've submitted the thesis to my primary supervisor, who is also in the process of review. And when he's done, he'll give it to the other professors on the committee to look at. And then I've submitted one research article to a journal, and I'm awaiting comments from the second reviewer. And then I've submitted one research article to my supervisor. So in all, I have 2 research articles that are pending and let me see, review. And then I'm in the process of drafting 2 research articles on my third and fourth objectives. So in terms of the pending task, I'm looking to submit the dissertation to KNUST when I'm done with the revision of the comments from my supervisors, and then a thesis defense later on. Thank you so much.
Thank you very much, Gideon, for the insightful presentation. So comments, input, feedbacks. We are starting from our online audience. Okay, no hand yet from our online audience. Any feedbacks, any comments, inputs, or questions?
Maybe I could just say that it's very good and maybe also encouraging for some of the new PhD students now to see how some of the other older like the more advanced PhD students are finishing everything, and how things are coming together very nicely I think this is a good example in this PhD, how the quantitative and qualitative results basically complement each other. But I was wondering, maybe can you explain a bit how you integrated that, or how you integrate for yourself, how you make sense of the different things that you find from the quantitative and qualitative results, and how potentially the qualitative results help to explain some of the quantitative findings also?
Okay, thank you so much for the question, Prof. Quentin. So integration was largely at the discussion stage in my thesis, and let me say from the starting point, I didn't want to say the qualitative results will explain necessarily what's happened in the quantitative stage, but then the qualitative stage set to complement what we couldn't obtain through a quantitative methodological process. So in terms of integration, the qualitative was more of a, let me say, complementary. So for example, things we couldn't quantify, like the absence of oxygen equipment, issues regarding staff motivation, issues regarding work overload that we couldn't measure in the quantitative phase were talked about in the qualitative phase, and which added more to the, let me see, the broad issue about the determinants of the mortality from different perspectives. So basically, I'd say the qualitative phase complemented the quantitative phase and gave us more insights or other dimensions or other explanations to what we had in the quantitative phase.
Okay, thank you very much, Gideon. Dr. Daniel, we had your hand up. Dr. Daniel.
Yes, and I hope you can still hear me.
You're cutting out a bit.
Hello?
Hello?
Yes, Dr. Daniel, we can hear you.
Yes, yeah. So if you can hear me, then I wanted to ask Gideon, maybe following up from Wilm's question, that when you take yourself out of the work, I mean, you're too much of a scientist and a researcher into the work. When you take yourself out of it, what really are the key takeaways that you think your work, the whole PhD, has been able to achieve or address that is relevant really for policy discourse?
Okay, so for me, if you ask me, one of my, let me say, striking findings is the fact that there are issues at our facility level. Of course, there are determinants at the patient level. Individually, we all have various risks, which, of course, if proper health education is done, we can manage it to some extent. But then at the facility level, which I'd say is our last, or let me say, almost last point of resort, we have so many issues. We have equipment issues. We have systemic issues. I'm talking about referral bottlenecks. So this study has brought out what we face, issues we face within the health sector when it comes to emergency preparedness, especially at the facility level. There are so many things we have to address to put ourselves in preparedness of the next pandemic. And that's what this study has brought to bear. There are facility level determinants of mortalities when it comes to pandemic infectious diseases. And if we address that based on the findings of this study regarding equipment, regarding staff motivation, regarding referral systems, we can do a lot for ourselves in terms of epidemic or pandemic response. Yes. Thank you.
Thank you very much, Gideon. If there's no other question from our online and on-site audience, Then we shall be handing the floor to our center director in the person of Professor Mrs. Linda Debra. Thank you.
Thank you very much. Thank you very much. Okay, so Gideon, oh, don't go yet. Just
Okay.
yes, but I saw your timelines, and I'm happy. Except that you said you have one drafted manuscript that you've submitted, and it's in review. But we need 2 for completion, right?
Yes.
So,
Okay. Oh, sorry.
do you think the ones you are
Okay, so I know one is a conference paper, which I already have a conference publication, which I have not, unfortunately, apologies, I didn't put on the slide, but I have a conference publication. So with this very one that I mentioned is under review at one of the journals, it's the research article.
Okay.
Sorry, no.
It's a research article, you said?
Yes, please.
Okay.
But for the conference publication, I already have one.
Okay, thank you. So when should we expect you to complete?
Are you referring to publication of the manuscript under review?
Complete school.
Complete school?
Yes.
Okay. I'm hoping I can graduate in November, but then that doesn't depend on me alone. So I'll be working closely with my supervisors in the committee to come to that realization.
Okay, so I think the part you are pushing on supervisors, they are listening. So they will play their part. Then it's up to you. I read that your supervisor says you should do more than one research article. So
yes.
Yeah, so you have to work on the other one as quickly as possible. Yes. Thank you so much.
Thank you.
We are expecting we were expecting 3 more presentations, but unfortunately they are not able to present. And so we'll draw down the curtain on our colloquium for today. We look forward, the GWAC family, we look forward to our meeting, our steering committee meeting in next week, 18th. And so I would wish our online participants a very good day, and I thank you all for making time to be available for this colloquium. Thank you, and we will talk later. Yes. So, ladies and gentlemen on site, this is the moment where we have to do our panel discussion. And so our MC, our chief panelist is on her way here. And I'm sure we have our other panelists also around. We will take it up from
Recording in progress.